Hi everyone, a very good evening and I welcome you all to the FARRE series. If you have joined us, come and say hi in the chat box. I would be eagerly waiting to say hi to you. Hi Rohit, how are you? Good evening. Right. So, guys, we are going to start talking about hepatobiliary tract infections. The purpose of FARRE is to quickly revise, right? So, we're going to quickly revise, go through all of the important, we're going to cover the entire unit today. Like, there's nothing that we're going to leave out because everything is important from this unit. It's a relatively smaller unit, but something that students are very, very scared of, right? So, of course, we are going to read all of the viral hepatitis, including yellow fever, right? So most of the time students forget that hepatitis is not just hepatitis A, B, C, D, E viruses, but it is also the yellow fever, right? Then of course the parasitic diseases involved. Then larva migrans is something that we are going to cover, right? So larva migrans is very important for the students to know. They're mostly confused because it's some repeated pathogens which come into the picture, and then it's just really confusing. So we are going to get rid of that confusion as well. So wait till hi, good evening guys, very nice to see you. Wait till such a time that till the end of the class when we discuss this. So another thing that we are going to do this time in FARRE is that we are going to read it in the way that you're going to present in your exam. What is this going to help you do? It is going to help you build a picture memory, okay? A visual memory of it. So I have presented it in the way a student can or could write it in the exam. So while I'm speaking, while you're looking at the screen, just keep making that memory because exams are right here, not even around the corner. Exams are knocking on your door, right? So anything that you study at this point of time, any video that you watch, it should be directly fruitful for the exam. So that is the purpose. Not going to teach you the way we take understanding lectures or the live lectures. Simply going to give you exam oriented answers. That's it. That's I'm going to do today, right? All right. Hi, guys. Good evening. So, of course, you know that we're going to start with viral hepatitis. Please always remember that viral hepatitis means hepatitis virus A to E as well as yellow fever, right? This is your ticket to distinction. If you get a simple open-ended question on viral hepatitis, which is not significantly pointing towards hepatitis B or C or something, please include yellow fever in the answer. Yes, it is very much a hepatitis infection. Not seen in India, but very much a very significant disease, infectious disease. Good evening, good evening. So you know that when I'm talking about hepatitis A to E viruses, the transmission can be fecal-oral, blood transfusion, needle stick injury, sexual, vertical, and also fecal-oral. Why do we always write it like this? My students would know it that this side I will write hepatitis A, and on this side I will write hepatitis E, and in the middle I will write hepatitis B, C and D, right? So this becomes very, very easy for me to remember the fecal-oral route. Please also remember very much that the yellow fever virus is transmitted by the mosquito bite. Mosquito bite. And which mosquito? Of course, the Aedes mosquito, right? So that is all that we're going to cover amongst the viruses. Chalo, let's quickly begin talking. So this comparative table, this comparison table, I urge you to draw in your answer sheet, to make in your answer sheet, even if the question is limited to hepatitis B and C, because usually in the question they give you a long clinical case which might be open ended or which might be specific for hepatitis B and C, because what they like to ask you is transfusion transmitted viruses. So your DDs for transfusion transmitted become 2, which is Hep B and C mostly. Yes, but if they ask you acute on chronic or super infection or co-infection, in that scenario you have to write hepatitis D. Whatever may be the case, if whenever you can make a comparison table, always draw a comparison table. I always tell my students, whenever you're revising a topic, ask yourself 3 questions. Can I draw 3 diagrams from this topic? Okay, I have read the topic. Now, do I know it enough to be able to make at least 3 diagrams for this? Can I make a flow chart, a comparison table? Okay, a flow chart or a comparison table. I should be able to make at least one flow chart and one comparison table from each and every topic that I'm revising and I'm making. Can I tell the lab diagnosis on my fingertips. That is all that you need to assess from each and every topic that you're reading and revising. That is the purpose, okay? Passive learning, passive reading is not the purpose. Remembering random facts about organisms which they're not going to ask in exam is not the purpose. The purpose is, after reading, can you make at least one differences table? Can you make at least one flow chart? Can you make at least 3 diagrams from that topic? And is lab diagnosis on your tips? All right. So with that, I am giving you one comparison table for the hepatitis viruses. Yes, you're going to get this PDF. Please click on the link in the description, or it would be one of the first comments in the comment section. From there, you can get the links, the PDFs of this section, right? Right. So, like I said, always make a comparison table wherever you can. What are you going to write about? You're going to about the taxonomic family. Why do we talk about the family of these hepatitis viruses? Because we know that these hepatitis A, B, C, D, E viruses is not a taxonomic classification. They don't belong to the same family. They cause the same disease. So, they are grouped and studied together. But they do not belong to the same family. It is in fact people who come from different walks of life, okay, viruses which come from different walks of life, from different families, but they all come together and cause hepatitis. That is why we are reading them together, okay. So I know that hepatitis B virus is in fact the only DNA virus, and that is why the family also has the name Hepatidina in its name. So actually it is PADNA. And what is PADNA telling me? That it is partially double-stranded DNA virus. Yes, Hepatidina. Rest all hepatitis viruses are your single-stranded RNA viruses. So the first, hepatitis A, is that family which has RNA in its name. So it is Picornaviridae family, that is of hepatitis A virus. Then what about hepatitis C? I always tell my students that flavy, the word flavy means yellow or lime green or lemon flavored. Yes, so hepatitis C, C is for citrus. So from citrus you can remember yellow, and from yellow you can remember flavy. Therefore hepatitis C is the Flaviviridae family. Please draw this comparison table. Start your answer with the taxonomic classification. That is going to give you a high score. Yes. What is hepatitis D? D stands for delta, D stands for defective, D stands for dependent, because my hepatitis D virus is dependent on my hepatitis B virus. Yes, it belongs to the delta virus group. And when I say hep E, I just simply write it like that. Hep E viridae. You know viridae means family. So hep E viridae is the hepatitis E viridae family, right? So you will write the taxonomic classification. First is the one with RNA, its name Picorna. Second is the one with DNA in its name Hepatidina. C is citrus, means Flaviviridae. Then D is delta, and hep E virus is hep E viridae family. Right? Done. Then genome characteristics, like I said, they're all single-stranded DNA viruses except this particular guy, which is a partially double-stranded DNA virus. What is a partial double-stranded DNA virus? This is one whole strand, and then the other strand, I'm not going to make it complete. I'm going to leave it right in the middle. This is a partially double-stranded DNA virus. The second strand is incomplete. That second strand is not complete. Of course, we have seen fecal-oral transmission. This is the best way to remember fecal-oral. So first and last is fecal-oral, and in the middle, it is parenteral, sexual, vertical, and the first and last is of course fecal-oral, and all of these three are same. All right. I cannot read your comment. Let me just. All right. Clinical microbiology. Okay, fine. We can include a session. Not a problem. All right. So, हम आगे बढ़ते हैं. We are going to move ahead. Incubation period. See, incubation period is very, very easy to remember. Just simply in the first column, write 30 days. Okay. Then in the last column, write 40. Then in the middle column, write 50. 30, 40, 50. And now write 60 to 90. And like I said, hepatitis D is dependent on hepatitis B. So, of course, that is also going to be 60 to 90 days because it follows the hepatitis B virus. Yes. So that is how it becomes easy for me. General prognosis. You know, hepatitis A is acute. So it is acute virus. So of course, there's going to be 100% recovery. There is excellent prognosis of hepatitis A virus. It is gotten through fecal-oral route and there's excellent recovery. So there's excellent 100% recovery of hepatitis A, whereas you know that B can range from acute and spontaneous recovery up to hepatocellular carcinoma. So the range of hepatitis B virus prognosis can range from being good to poor. Whereas when I talk about hepatitis C virus, it is very, very poor. The most dangerous out of all of these is in fact hepatitis C virus. It's C for chronic, C for cirrhosis, C for complications, C for carrier, C for cancers. Everything which is bad about hepatitis viruses starts with C, and the most maximum risk for these C complications is associated with hepatitis C virus itself. All right. Now what? Then D is also poor. Actually, D is dependent on B. D cannot infect without B. But whenever D comes in the picture along with B, the prognosis overall becomes even worse than individual B itself. So if it's an isolated single hepatitis B virus infection, when it gets mixed with hepatitis D, the prognosis becomes even more worse. Okay. Then E is also generally good. So please make this, comparison table in your exams, no matter which hepatitis virus you're supposed to write about that particular. Or if, like I said, question says transfusion transmitted viruses, please write both hepatitis B and C viruses and make this comparison table wherein you write about the taxonomy, the genome, the transmission, incubation period, and general prognosis, right? Then you have to write about the clinical progression and complications. Like I was saying, hepatitis A and E are acute and self-limiting. There is no chronicity, cirrhosis, hepatocellular carcinoma or carrier state. Something which is acute makes sense that something which is acute will definitely not go into chronicity. Something which is acute will not go into carrier stage or cancer stage. Okay, it is acute, it will happen and it will go away. So there is good prognosis. Whereas hepatitis B can range from acute to chronic. The major cause of cirrhosis, HCC, and carrier state. It is in fact the most common cause of HCC, cirrhosis, and carrier state in the world, because maximum people, they are affected with hepatitis B. Hepatitis C, even though less common, but has associated with very high chronicity, up to 80%, and it leads to cirrhosis and hepatocellular carcinoma classically. So more than 80% of the people infected with hepatitis C virus will definitely go into chronicity. Okay, whereas only 5% of hepatitis B infected patients will go into chronicity. So over here, there is only 5% chronicity as compared to my hepatitis C, where there is up to 80% chronicity associated. So please write this in your answer sheets. HDV exists only with hepatitis B surface antigen. The reason that this virus is dependent on the B virus is because it does not have its own surface antigen. So it leads to superinfection and it leads to co-infection. So superinfection happens in hepatitis B virus carriers or chronic cases, and there the risk of cirrhosis and hepatocellular carcinoma increases by a lot, by a huge margin. Yes, so you will write about the clinical prognosis of all. So A and E are acute, B is good to bad, there is about 5% chronicity, but it does lead to cirrhosis and hepatocellular carcinoma as well. C has the worst prognosis of all, 80% people land in chronicity, and D makes the prognosis worse for hepatitis B. All right. Now you will write the clinical manifestations. Of course, every disease first presents with a prodrome. Okay, what is a prodrome? It's like a trailer before a movie, right? It's just a trailer. It is just showing you what's about to come. So simple fever, malaise, weakness, fatigue, and anorexia, which is the most common constitutional prodromal symptoms which happen with each and every viral illness. Okay, so whenever you're talking about dengue, chikungunya, hepatitis, yellow fever, any viral hemorrhagic fever, in all of them, the first prodromal stage always and always is simply fever, malaise, weakness, fatigue, anorexia. cachexia. Simply that, because that is the nature of all the viruses. This is what the viruses do to us. All right. Then we have the icteric phase. Now, icterus or jaundice has started. Now the liver is getting damaged, and you're seeing those signs. You're seeing the signs of liver damage now. So you have scleral icterus, that is jaundice. Of course, there is going to be dark colored urine, pale colored stools, nausea, vomiting, and right upper quadrant abdominal pain. Because of the liver involvement, you're going to have the right upper quadrant abdominal pain. Wherever you can, with whatever limited artistic skills you can, please draw simple diagrams along with your answers. Okay, just you have written right upper quadrant plane. You might not have such good drawing skills, but you can just simply draw a person and draw a liver over there and highlight it and then write right upper quadrant pain. So that just tells the examiner that you know that why this right upper quadrant pain is happening. It saves time, it makes the answer beautiful, and it puts the point across, right? So of course you have prodromal symptoms, which are common for most viral illnesses, especially for the fever causing viral illnesses. And then you have the specific symptoms which are specific to liver. So there is going to be jaundice, dark colored urine, pale stools, and nausea, vomiting, right upper quadrant pain. Of course, it is also going to be associated with elevated liver enzymes. Yes, so please write this also, elevated liver enzymes, because of course it is a hepatitis virus, so it is going to involve the liver. Okay, done and done. Next, what you have to talk and draw the morphology and diagram of the virus. Yes, what is the virus made up of? First, there is the genome, then there is the capsid, then there is the envelope, and then there is the small little surface proteins which are attached onto the surface. This is a whole particle. It has everything that a virus needs. A virus needs its nucleus, a virus needs its protein over the nucleus, a virus needs an envelope, and the proteins on top of an envelope. Viral structures are extremely simple. Viruses are only made up of 4 things, and that's it. There is nothing complicated in their structure. Simple, but very, very highly mutating. So every virus you draw these 4 structures. When all of this is present, that's a complete particle, and that is an infectious particle, and the name of that is Dane's particle. Okay, Dane's particle. So please draw Dane's particle. Every answer of hepatitis B is incomplete without drawing the Dane's particle. So how we draw this? You know, hepatitis B virus has a partially double-stranded DNA. So I will only draw a partial strand. After that, I'm going to give it a nice nucleocapsid. A nice capsid I will give it. Then I'm going to draw the proteins which are present on the envelope. So these are the surface proteins which are present on the hepatitis B virus. Then I will draw these proteins. Then there is a protein which is just floating in between like this. Okay, just floating in between the core of the virus and the surface of the virus. This is a complete Dane's particle. Nothing can get simpler than this. I mean, this you can definitely draw in exam. Yes, correct, Devanshu. Oh, that's excellent to know. Nice. Right. Then, so of course, you're going to label it. What is this? This is something present on the surface of the virus. So this is the surface antigen. So what can I call the surface antigen? I can call it as hepatitis B surface antigen. Okay. It is the hepatitis B surface antigen. Then what is this? This is the core of the virus. Yes. This is the very core. This is the very center of the virus. So if this is the core, then I can call it hepatitis B core antigen or HBC antigen. Please, the guys, don't confuse hepatitis C virus and hepatitis B C antigen. Okay, this is an antigen of the hepatitis B virus, while this is a whole hepatitis C virus by itself. Right? If I move in the virus from outside to inside, I will first hit the surface antigen, then hit the core. If I end up hitting something in my path before I hit the core, then that would be this pink guy. Yes, so this is something which I can call as a pre-core antigen because it is pre or before the core. So this is what I call as the pre-core antigen. Can I write it as hepatitis B E antigen? Okay, again, please do not confuse hepatitis E virus and hepatitis B E antigen. Okay, this is the antigen of hepatitis B virus and this is the hepatitis E virus in itself. Okay, on its own. Please understand These differences, don't let the panic of exam confuse you. Okay, then what is this? This is nothing but the genome of my virus. And what is the genome of my virus? It's a partially double-stranded DNA virus. That is why the name Hepatobiliary, okay? PADNA, Hepatobiliary, okay? Excellent. Now, this is a whole particle. This is a dense particle. Please draw this dense particle in your answer sheets. Now, sometimes when I have to give vaccines, I don't like to give the whole particle. Why? Because this guy is infectious. This guy is dangerous. This guy is able to replicate and cause dangerous consequences. So, when I want to give a vaccine, I will simply pick this subunit, okay? I will pluck this subunit off of the virus. So what I have when I want to give a vaccine, I only and only have the surface antigen, but it is empty from inside. So it's like an empty ring. If I break this ring from two ends, it's going to open up into a tube or tubular structure, right? So what is that? That is the tubular virus. So you can also have certain incomplete particles, which are the spherical particle and the tubular particle. The main use of these is to give as in the vaccines or to use in the lab diagnosis as antigens. Please remember that these incomplete particles are not infectious. So the spherical particle and the tubular particle, which is nothing but simply and only made up of the surface antigen of the virus, they are non-infectious forms. Okay, they are non-infectious forms. They are mainly used in lab diagnosis and mainly used in vaccines. So please draw a dense particle, draw a spherical particle, draw a tubular particle, and write the things about it. It is super important for hepatitis. Oh, thank you so much. Means a lot. I would also like to wish all my gurus a very happy Guru Purnima as well. All right. Hanji, next क्या है आपका? Next is viral antigens and clinical significance. These antigens that we have just seen, what is the significance of these antigens? What do they tell me? When I'm testing the blood of a person, of a patient, I come across hepatitis B or C or any of these antigens. What does it mean? What is the meaning of it? All right. So let's see. When I say hepatitis B surface antigen, it means active infection. So I always like to tell my students, always remember S means sick. S stands for sick. Actually, S stands for surface antigen. But for us to remember, we can remember S stands for sick. So the person is sick. They have an active infection. And that is why my body will produce antibodies against this particular antigen. Because this is the main antigen involved in active infection. This is the target for the neutralizing antibodies. And therefore, it becomes the basis of vaccine. That is why instead of giving this whole dense particle, I was simply giving the isolated surface antigen particles in the form of vaccine. Then you have hepatitis E. E is secretory antigen. It is a marker of high replication. What is this telling me? Whenever a patient comes out to be hepatitis E antigen positive, it is telling me that the patient is highly infectious. The patient has high infectivity. Patient has high infectivity. High infectivity. All right, that is what it is telling me. So every time you have a hepatitis B surface antigen positive person, you know that the person is sick. Person has active infection. On top of it, the person turns out to be HBe antigen positive. This is also a person who is highly transmissible, is going to highly transmit the disease to other people. Person with HBC antigen will never be found, okay? Because it's the core antigen. It can only be seen inside the hepatocytes. It is never found, not detectable in the serum. Because the virus will never leave its core. It will never leave the core, just leak out like that. So, but it will only uncoat itself inside the hepatocytes. Inside that one particular organ where it is supposed to cause a disease, only there is it going to uncoat itself and expose its core to the hepatocyte. So, do you think my body is going to make antibodies against all? Yes. The main neutralizing type, neutralizing antibodies means killing killing antibodies. So there are some killing antibodies and there are some binding antibodies, okay? So the killing type antibodies are mainly produced against the surface antigen, but they are of course also produced against the pre-core antigen, but core antigen is not coming out in the serum. So is it going to produce antibodies? Yes, still my body will still produce antibodies against this. And in fact, they are going to be the most important antibodies I detect for hepatitis B virus, because these are the ones which are always going to be elevated irrespective of the phase of illness of the patient. Patient might be in acute disease, patient might be in a chronic state, patient might be a carrier, patient might have recovered from hepatitis B 20 years ago. But one thing that I can always find in his blood is the antibodies. Please guys, antibodies against this antigen, not this antigen, okay? And even there is something called as a window period which is seen with hepatitis B virus as well, not just HIV virus. So even in that phase, I can always detect these antibodies against this antigen. All right, so let me just draw the serology. So you're also supposed to write about the serology of hepatitis virus. So please and please draw this diagram for serology. What do? It is quite simple. Okay, it is quite simple. Simply draw a graph. I have always told you and even previously told you in answer writing series that wherever you can fit in, wherever you can just squish in a graph for any disease, please do that. Okay, so especially for viruses, if you can draw the serology of them, please draw it. And where are you going to draw it? You're going to draw it in the lab diagnosis section. You're going to draw it in the lab diagnosis section, but I'm explaining it to you now because we're already talking about antigens. Yes, we will do that, Vidushi, we will do that. Yes, so we are already talking about the antigen. So now we might as well talk about the antibodies. Okay, so what did I say? Virus has three antigens main: surface, E, pre-core and core. Core is something which never comes out. So surface is something which comes out first. Yes. So the first of all, the moment the virus enters in my body, the first antigen that it will show to my body is the hepatitis B surface antigen. So the first antigen to rise and then yes, of course, eventually fall is your hepatitis B surface antigen. Okay, this is the guy which rises the first. Then not too far behind is this copycat, which is hepatitis E virus, hepatitis E antigen of the hepatitis B virus. Okay, this is not too far behind. This comes right after it. Now, like I had said, the first antibody to rise is not against this guy, but the first antibody to rise is actually against the core, because the body really wants to hurt this virus. So instead of just attacking these superficial antigens, it is going to go and attack the core of the virus. So please do not say, yes, the first antigen to rise is the surface antigen, but the first antibody to rise is the antibody against the core antigen. So that is going to rise somewhere right here, okay? It is going to start rising right here. Right here, it's going to start rising. What is it? It is anti-hepatitis B core antibodies. Of course, the first set of antibodies which will come will be IgM. Okay. By this time, it is time for the anti-hepatitis B surface antibodies to also rise. Please remember that only when the antigen falls does the antibody for it rise. So here is anti-hepatitis B surface antibody, right? Similarly, the pre-core antibody will also come in the picture. So over here, your anti-HBE is also going to rise. Okay. What about this? It will now start producing the IgG type, right? So it will now start producing IgG. So it will now go on and in the form of IgG. So which is the antibody which is always present in this disease? It is just the pink one. These guys have not risen in the acute phase. Only the pink thing is present in the acute also and in the chronic also. So this is what is present always. You know what is this period called as? This period where the surface antigen and pre-core antigen has fallen and their antibodies have not yet risen. This period is called as window period. This is the window period. So what can I do to overcome the window period? I can simply detect anti-HBC antibodies. All right, so you can easily draw this graph. It is not a something, rocket science kind of a graph. It is in fact quite easy, very, very easy. Just simply write that this is the number of days here, and this is the titers over here that we are talking about, antigens and antibodies which are rising. Okay, done and done, right? Now let's quickly move on. And let's talk about the genome of the virus. This partially double-stranded DNA that we saw, what genes does it even have? So usually whenever you're supposed to draw a DNA, you're supposed to draw two strands. But this feels a little complicated for many students. So I mean, just chuck all the rules. Who cares? It's university. The examiner should just know that you know the thing. Simply draw a line, man. Who cares? Even though a line is to be drawn for a single-stranded RNA, but if this is difficult, then it's better to draw something than not drawing anything. Okay? So you have, every virus genome is going to code for all the important structures in its shape or morphology. So what are all the important structures in hepatitis B virus? There is the surface antigen, there is the core antigen, there is the pre-core antigen. Okay, so all of these little genes are going to code for it. You have the S region in the genome. S region codes for the surface antigen. So this is the guy which is going to code for the hepatitis B surface antigen. Then you have the C region. C region codes for the core, the HBC antigen of the virus. Yes, it codes for the core of the virus. Then P codes for the polymerase. Pre-core. What does pre-core code for? Pre-core will obviously code for the pre-core antigen, right? So this codes for the hepatitis B E antigen, all right? What if there is a mutation? What if this undergoes any mutation? This portion goes mutation. The person will be called as a pre-core mutant. A pre-core mutant. Okay. What if there is a mutation in the surface antigen coding region? Then surface antigen will not be formed. What is my mainstay of diagnosis? To detect the surface antigen. So I will not be able to detect these patients. So these patients will escape my diagnosis. So the people in which there is mutation of the surface antigen are called as escape mutants. Okay, there is increased hepatocellular carcinoma in these guys, because not just escaping the diagnosis, they're also escaping my immune system, because against which antigen was the main neutralizing antibody being formed? It was being formed against the surface antigen. When surface antigen is not getting expressed, my body is not fighting the virus. So the virus can easily live in their body, and therefore it increases the risk of hepatocellular carcinoma by a lot. So escape mutants are always at a risk of hepatocellular carcinoma. Good evening, Arpita. Yes. Then what is a pre-core mutant? Like I said, there is a mutation in the HBE coding region, the pre-core region. But so when you test the person, HBE antigen is negative, but the virus still replicates. What is this X protein? X protein is coding for the oncogene responsible for causing hepatocellular carcinoma. So make sure you're drawing all the genes required for surface, S region for pre-core region, for the core region, for the polymerase, and X for cancer. Okay, oncogene. Please make sure. And you're also writing about the two mutants, which is the escape mutant and the pre-core mutant. You have to write about the disease progression. What is the meaning of that? Okay, so up till now, what have we done? We've talked about the clinical features of the disease. We have looked at the virus. We have looked at the genome of the virus. We have looked at how the body is going to behave against the virus. When does the antigen rise and fall? When does the antibody rise and fall? Now we have to see that how does the disease progress. Like I said, in the very first table of comparison that we have drawn, we have made these, big claims. We have made these big claims of prognosis. So how do we justify this prognosis? It is by writing these, progression of the disease. That how does the disease progress? What does it lead to ultimately? So whenever there's a person who gets hepatitis B, 90% of them recover. 90% of those people recover. only 5% go into chronicity, and less than 5% people become carriers. Okay, and in these carriers there can be some super carriers and some simple carriers. Now you only tell me, what is a super carrier? Somebody with high infectivity. So a super carrier is always going to be HBe antigen positive, because a super carrier has to be highly replicating and highly infective. Another thing that you will add over here is that less than 1% people, they go into fulminant disease. Yes, less than 1% people go into fulminant disease, but all of them show 100% mortality. So being in the less than 1% category will be quite unlucky for a person. Okay, so it's not always best to be, you know, in the select few 1%, in the top 1% of the society, because if you are in the less than 1% of the society for hepatitis B virus, 100% you're going to die. Okay, so 90% recover. Then you have the remaining 10%. Out of that, 5% go into chronicity. Out of the remaining 5%, less than 5% become carriers, and less than 1% go into the fulminant or the spreading type of a disease. Okay, and out of the carriers, there can be simple and super carriers. So a super carrier is going to be highly infectious. So that is the one which is going to be positive for the hepatitis B pre-core or the HBe antigen. All right. Then what about the vaccination protocols? What about the vaccination protocol? You have to make the HBV vaccine. The HBV vaccine only and only contains the surface antigen of the virus. How do I inject that? I take that surface virus gene and I inject it into a baker's yeast, and then this yeast starts producing the surface antigen on its surface. Then the body starts recognizing the antigen and attacking the antigen. So it's a part of the national immunization schedule. All of us have gotten the hepatitis B vaccine in our childhood. It is given on the 6, 10, 14 weeks, along with the pentavalent vaccine, which is DPT, Hib for H influenza, and 5/5 is hepatitis B. In the adult schedule, it is given at 036 or 026, or 3 doses are what are given. 3 doses are given. So it is either 036 or 136. Okay. Then we have protective threshold. This is the most important thing you need to know. Okay, there is one thing which is that you're vaccinated. What does it mean? It is the act of taking a vaccine. You have the certificate. You have taken the injection. You have the certificate. That simply means you're vaccinated. Did that vaccine help? Did you even produce antibodies against that virus in the form of vaccine or not? That is protected. So you might be vaccinated, you might not be protected, or you might be vaccinated and also protected. So how do we know that? We measure the levels of antibodies. What if the threshold is 10 million international units per ml? If the person has more than 10 million international units per ml of anti-hepatitis B surface antibodies, that means they are protected. Now, if a hepatitis B virus enters them, they will be protected. Okay, they are not going to succumb to the disease. So that is the threshold that we have to see. And then there are some guys who are non-responders. Very important question. So what is a non-responder? It can come as an explain why question. Please note that the non-responder thing can come as an explain why question. They might ask you, explain why some people don't form antibodies even after taking the schedules, or explain why some people are called as non-responders. So who are non-responders? Like I said, the vaccination is given in 3 doses. So they have taken the 3 doses, then they went and got their antibody titers checked. It was less than 10 million international units per ml. So they went and took another schedule. Again, they took 3 doses of vaccine. Still, it did not rise. Still, it led to, the titers did not rise more than 10 million international units per ml. So what does that mean? That these people are not responding to the vaccine. They are non-responders. Okay. So they are not responding even after taking 2 full courses. So either you say 2 full courses or you say 6 doses of the schedule of the vaccine. Still there is no rise more than 10. Still their titers remain less than 10. So even after 6 doses, they have less than 10 milli international units per ml of titers. Please write these 2 terms in your answer sheet. Even if you forget to write about the vaccines, please write about the protective threshold and non-responders. Okay. Then you have to look at So this is simply the table which I have shown you in the form of a graph. So you're going to draw that over here, that HBS antigen is the first antigen to rise. Then there is the precore. That is what we have drawn in the graph, that the first antigen to rise is HBS, then there is the precore. So this flow chart is simply explaining the graph. Then the first, antibody is anti-HBC, then there is anti-HBS, IgM and IgG. चलो नेक्स्ट क्या है पोस्ट एक्सपोजर प्रोफाइलैक्सिस व्हाट इज द मीनिंग ऑफ पोस्ट एक्सपोजर प्रोफाइलैक्सिस यू आर healthcare worker, you are a doctor, you are treating a patient, you get a needle stick injury from that patient, or you get exposed to any person, you needed blood transfusions, you got contaminated blood, anything. So you have gotten exposed to hepatitis B virus. Now you have to be given certain drugs so that you don't worsen, okay, so that you don't fall over onto the other side. There is prophylaxis, you have to be prevented, okay, the disease has to be prevented. So after exposure, example, you got a needle stick injury, you have to first check whether your antibody titers are enough or not, okay. Suppose you got pricked and the source was positive, okay, you got pricked from a positive person, the source or the patient was positive. Now what? Now we don't look at your vaccination status, we only look at your protection status. We get your antibody titers done. If your antibody titers are more than 10 mini international units per ml, you're totally protected and you take no further action, you can simply chill, okay. If it is less than AC chala do, AC chala do. If it is less than 10 million international units per ml, then you're unprotected. Now, special attention needs to be given to you. If you are not protected because you were never vaccinated, then you have to be given the immunoglobulin as well as the vaccine course. So, whenever a person is unprotected, the first thing that you do is you give them human immunoglobulins, okay? Hepatitis B immunoglobulins, first thing that you do. Now, along with this immunoglobulin, will you give a vaccine or not? That depends upon the vaccination status. If you were never vaccinated, you take the immunoglobulin as well as the vaccine. If you were vaccinated, then you take the immunoglobulin and you simply take a booster. If you are a non-responder, the third possibility is that you are a non-responder. In that case, there is no need for giving a vaccine. So you simply take the immunoglobulins twice. Okay, so you simply take the immunoglobulins twice, that is, you take the 2 doses of immunoglobulins. सिस्टमिक में क्या इंपॉर्टेंट है सी सिस्टमिक में बहुत कुछ इंपॉर्टेंट है ओके सो द थिंग इज दैट इन द फर्रे सीरीज वी कवर द मोस्ट इंपॉर्टेंट टॉपिक्स इटसेल्फ सो your name's quite funny, baby test tube. I think you should attend the FARRE series because in this we are going to cover the most important topics. That is what is important in systemic. Otherwise, systemic is huge, right? What can you miss and what can't you miss? Nice to know, Achintya, that you could answer all the questions after watching the lectures. Thank you so much for the compliments. You can, of course, contact me on through my Telegram, okay? Please ping me on my Telegram or Instagram and I shall give you the details. All right, so let's move forward. So we are done with hepatitis B. What do we remember? We remember the comparison table. We remember the morphological diagram. We remember the serology that we have made. We remember the post-exposure prophylaxis and we remember the vaccine, okay? What about lab diagnosis? See, it's quite simple now. What will you test in lab diagnosis? All of these antigens you will test in lab diagnosis. So in the lab diagnosis, even if you simply draw this diagram, it is enough. That is what you will do in lab diagnosis, okay? Along with this, of course, you can also do the hepatitis B virus PCR, wherein you can detect the DNA of the virus. Okay, done and done. Now let's talk a little about the hepatitis D virus. So like I said, hepatitis D is defective and it is dependent. It is defective because it does not have its own surface antigen. It does not have its own surface antigen. Therefore, for this surface antigen, it is D for dependent. It is D for dependent on whom? On the hepatitis B virus for its hepatitis B surface antigen. So who is this? This guy with the partially double-stranded DNA and the surface antigen, this is the hepatitis B virus. If you look at this guy, this has a single-stranded RNA. But if you see that these proteins on the surface are exactly the same. So what has happened? This guy has borrowed the surface antigens onto itself. So a hepatitis D virus borrows the surface antigens of a hepatitis B virus. It is dependent on hepatitis B for its surface antigens. Alright. So how you're going to write the answer? You're going to say HDV is a defective virus that requires the presence of HBV to borrow the HBs antigen for its own envelope. Okay. So simply you will draw. This is a single-stranded circular HDV RNA. It has taken the surface envelope borrowed from hepatitis B. Simply draw it. Also draw it. See, this is hepatitis B. Hepatitis B has given its surface antigen and this guy has taken it over. Okay. This is dependence on hepatitis B virus. So what is the pathogenesis? HDV requires HBsAg. Formation of infectious HDV particle happens. It goes into the hepatocytes and the replication of the HDV RNA in the nucleus. Then of course the assembly of the virus and release of the new viral particles. But this can only happen in the presence of hepatitis B virus. What are the key points? It is defective, it needs HBV. It cannot infect without HBsAg. Therefore, a hepatitis D infection is always associated with the hepatitis B virus infection. Okay. Super infection is always more severe than co-infection, and prevention from HBV can prevent from HDV. This is very important line that you're going to write. Very important line. Prevention of HBV prevents HDV infection. So simply the fact that all of us are vaccinated and protected against hepatitis B automatically protects us against hepatitis D. Okay, that's a beautiful, excellent thing to happen to us. So there are two possible scenarios in which hepatitis D पक्का होगा इशिता ऑलवेज बिना हेप बी के एच हेपेटाइटिस डी इन्फेक्शन कर ही नहीं सकता पक्का होगा एज अ रूल होगा ठीक है all right so there are two possible clinical scenarios which can happen in the hepatitis D infection. What are those? Either a co-infection or a super infection. The names are explanatory. What is a co-infection? Both of them come together. Okay, both of them come together. So hepatitis B and hepatitis D, both of them are going to come together. What is super infection? If I take one picture, photo, and I put another photo on top of it, what is that? A superimposed image. So if there is already hepatitis B infection, on top of it hepatitis D infection also happens. This is a super infection. So one on top of the other is hep D and together both is co-infection. So what happens in co-infection? There is simultaneous infection with HBV and HD. Both viruses enter at the same time. So both have come and they have caused an acute infection. Okay. There is 20% increased chronicity as compared to hepatitis B alone. Okay. There is 20% increased chronicity. So the outcome is poor. Initially with only hepatitis B, there was only 5% chance of chronicity. But now in co-infection with D, there is 20% rise. 20% more chances that chronicity will happen. What about superinfection? HDV infection happens in an established HBV carrier. So already a person had hepatitis B. On top of it, HDV comes. This causes severe disease. HDV joins later in a person already infected with hepatitis B virus. Okay, there is 100% chronicity. There is 40% increase in carrier state and more than 20% increase in mortality. So like I said, super infection is more severe than co-infection. Super infection is always worse. Okay, it's a super infection. It is always worse. So you have to do, you can also make a comparison table. Like I said, whenever you can make a comparison table, make a comparison table. So you will write both enter simultaneously. It enters in an established carrier. Here 20% increase in chronicity, 100% increase in chronicity. Carrier state is slightly increased. Carrier state is 40% increase. Clinical severity is moderate. Over here it is very, very severe. And mortality is usually low. Here there is more than 20% mortality associated. So whenever you can make a differences table, please go ahead and make a differences table. This is the rule of writing university answers. Now we got to talk about the hepatitis C virus. So look at this guy. Of course, the genome is going to be a single-stranded RNA, no doubt in that. Yes, and of course, it is also going to have a core. It is also going to have an envelope, and on top of the envelope, there are going to be these proteins. What are these proteins? Envelope proteins. Envelope protein 1 and envelope protein 2. E1 and E2. This is the simple, easy diagram of hepatitis C virus. What is the genome? Single-stranded RNA, and it encodes 3 structural plus 6 non-structural proteins. This is must know about the genome. So you will simply draw a straight line, you will draw a genome, and you will say that there are 3 structural proteins which are coded and 6 non-structural proteins which are coded by this virus. So 3 structural proteins are the core, which is the core, the E1 and the E2, because these are what is making the main structure of the virus. Then the non-structural proteins are going to be non-structural 2, 3, 4A, 4B, 5A, 5B. Okay, the 6 guys are going to be here. What is the core going to code for? The nucleocapsid. What is a nucleocapsid? Nucleus as well as the capsid is a nucleocapsid. Okay, what is this going to code for? E1 and E2, they will make the envelope glycoproteins. Okay, enveloped glycoproteins. This guy replicates, this release the replicase complex. Handmade diagram. What is difficult in making this diagram? What can you not understand from this? Simply draw a single-stranded RNA, right? And then simply draw a nucleocapsid around it. Then simply draw an envelope. And on top of the envelope, simply draw the glycoproteins. This is what each and every damn virus looks like. Yes. So we have always learned that this is what a virus looks like. Please draw this. Easiest. Viruses are always the easiest to draw. This is a hepatitis C virus. Okay. Then you draw, then you write it. What is this? This is a single-stranded RNA. What is this? This is a capsid, icosahedral capsid. What is this? This is an envelope. I mean, of course, you know it by now, right? Then what is this? This is the peplomers. Peplomers or the envelope proteins. This guy has 2 envelope proteins. What are those? It has one which is E1, one which is E2. So simply draw 2 types of envelope proteins. 2 type of envelope proteins. What are those? This guy is E1, this guy is E2. They are proteins which are attached on the envelope. Okay. So they are envelope proteins. Yes, this is the dictum. All right, Amit. Okay, this is the dictum. It is quite simple, right? What is the problem? Every time you try to draw a virus, think of the 4 things. Is it DNA? Is it RNA? Make the capsid, then think, does it have an envelope or not? Non-enveloped viruses will stop right there. But enveloped viruses will have an envelope. And then there are the glycoproteins. Same thing we have seen in a 3D diagram. Please draw this structure. Make the 3 structural proteins, the core coding for the nucleocapsid, E1 and E2 coding for the envelope proteins. And then the non-structural genes, NS2, 3, 4A, 4B, 5A and 5B. Now, the problem is in this E2. The problem is this E2. Why is there a problem? Because this E2 is the hypervariable region of this virus. What is hypervariable? Something which does not stay constant. Something which keeps varying very, very fast. So this E2 keeps on changing. There is constant mutations which keep happening in this E2. Therefore, this virus escapes from our immunity and leads to high chronicity, right? That is the reason that this virus is associated with more than 80% chronicity. So, explain why. This is again another explain why question. Explain why a virus is associated with high chronicity, hepatitis C. Explain why there are no effective vaccines against hepatitis C virus. Explain why there are no effective vaccines. So you can now write. Why? What is the reason? Because the E2 glycoprotein against which neutralizing antibodies will be made. that is hypervariable, that keeps changing. So the body is not able to produce immunity. Similarly, we cannot give it in the vaccine, because in the vaccine we have to give the main antigen. What is the main antigen? This E2 is the main antigen, and that keeps changing the shape. Why is there chronicity associated? Because this E2 keeps changing the shape, and my body cannot just keep making antibodies all the time. That is why the virus is nicely able to sit in the body, nicely able to evade the immune mechanism of my body and lead to chronic type of an infection. All right, so to explain why it's done with hepatitis C virus here. Then hepatitis C is also associated with complications, and not just hepatic complications. So what are the hepatic complications of hepatitis C? Chronicity, cirrhosis, and hepatocellular carcinoma. That, of course, there is maximum association with cirrhosis, hepatocellular carcinoma, and chronicity when we talk about hepatitis C virus. So C is everything C. Yes, what is hepatitis C virus? It is everything C. So there is the hepatic complications. That is the things which are going to complicate hepatitis. What are those? Hepatocellular carcinoma and cirrhosis. Cirrhosis. Then of course it also has extrahepatic complications. What are extrahepatic complications? Those are the ones which are not in the liver but outside. So what is that? This is cryoglobulinemia. Cryoglobulinemia. What is the next letter? R. So rheumatoid arthritis. Rheumatoid arthritis. And then there is the glomerulonephritis. Glomerulonephritis. So of course you can see glomerulonephritis, reactive arthritis, and cryoglobulinemia. All of these are extrahepatic complications associated. Oh, thank you, Dr. Monty. Right. So they are going to be the extrahepatic complications of hepatitis C. फिर क्या है diagnosis and management में? There is two-step testing. This is supremely important to write in your answer sheets. कि हम क्या करते हैं इसके लिए? While everyone else was quite easy and straightforward, detect the antigen, detect the antibody, detect the RNA, no problem. But what is the two-step testing for hepatitis C? First, you do a screening test and then you do a confirmatory test. How is it done? First, you do a screening. First, you do an ELISA and you try to detect anti-HCV antibodies, anti-hepatitis C virus antibodies. If it comes positive, then in the step 2, you do a confirmation. And that confirmation as a gold standard is done using an HCV RNA PCR. Okay, as a gold standard, it is always hepatitis C virus RNA PCR. Initially, there used to be something which is called as RIBA, recombinant immunosorbent assay. What is that? That is nothing but Western blot. But now we don't do RIBA anymore. What do? We simply do a PCR or a core antigen assay. So first you do an ELISA in which you detect anti-hepatitis C antibodies. And then you do an RNA PCR wherein you detect the RNA of the virus. ठीक है? Treatment goal क्या है इसका? What is the treatment goal? The goal is simply we achieve a sustained viral response. That is undetectable viral load. Okay, undetectable viral load. The goal is not to kill it, but to keep it at a low level. You can add directly acting antivirals and you can add the pegylated interferons plus ribavirin. Ribavirin is the treatment of choice. Wow. Good job, Vaishnavi. 17 MCQ and 1 LAQ correct हुए. Good job. Well done. Well, thank you for giving me the compliment, but it's of course it's all your hard work as well. Good job. चलिए. Next. Next is what? Next is now yellow fever. What is yellow fever? Yellow fever is also called as hemorrhagic hepatitis. ठीक है? What is yellow fever? It is hemorrhagic hepatitis. Oh, another thing, guys. When you make the differences table between co-infection and super-infection, simply you can also write the differentiating lab diagnosis. Differentiating lab diagnosis. What is that one marker which will differentiate the two? It is the anti-HBC. So, if the anti-hepatitis B core is IgM type, right, then it is a co-infection. if the anti-hepatitis B core is the IgG type, then it is a super infection. This is the one antibody which can differentiate the two conditions. Okay, the two conditions. Of course, all other things are going to be, high commonly. So this will also have hepatitis B surface antigen. This will also have hepatitis B surface antigen. Yes, this will also have hepatitis D virus RNA. This will also have hepatitis D virus RNA. But the thing which differentiates the two is this, that here it will be IgM type of anti-HBC, here it will be anti-IgG type of anti-HBC. Okay, please include this also. So we are done with the hepatitis viruses. Now we need to talk about yellow fever. Like I said, what is yellow fever? It is hemorrhagic hepatitis. So there are all the signs of hepatitis. What are the signs of hepatitis? The yellow eyes, which is the icterus, the dark urine, which is the hematuria. Then hemorrhages. When hemorrhages happen, there will be vomiting, blood, diarrhea and slow pulse, which is going to be seen. How is it spread? It is mosquito borne. It is mosquito borne by the Aedes aegypti. Yes, by the Aedes aegypti. Aedes aegypti mosquito. And the vaccine which is used against yellow fever is the yellow fever vaccine, which is the 17D strain of vaccine. 17D strain. So let's look at how we are going to attempt the answer. How we are going to attempt the answer? General features, it's mosquito-borne hemorrhagic hepatitis. It is absent in the Indian subcontinent. So it is totally absent. It is not seen in India. Absent in India, and that is why every time at the airport somebody comes from the African countries, they need to present the certificate of the 17D strain vaccine. Only then they get entry inside India, because we do not want yellow fever over here. Okay, 17D strain live attenuated vaccine is mandatory for travelers to endemic zones. So travelers from South America and Africa mandatorily need to produce the 17D vaccine strain certificate. Was it? What is it? It is a live attenuated vaccine. It is a live attenuated vaccine. All right, excellent. So what is it going to cause? Like I said, high fever, relative bradycardia, scleral icterus and dark urine, hematemesis and bloody diarrhea. Infected mosquito bites, it goes in the blood, goes to the liver, causes hepatocellular necrosis. Therefore, there is jaundice plus hemorrhagic manifestations, and in severe cases, multiple organs get involved and damaged. Who is it? It is Aedes aegypti, or the tiger mosquito, which causes yellow fever. Then you have certain important parasitic infections. You know that we classify the whole parasitology world into 4 categories. You have the protozoan and you have your helminths. Okay, amongst the helminths, you have cestodes, trematodes and nematodes. Yes, each one of this category can cause hepatobiliary or liver infections or hepatitis. Okay, protozoa mein there is amoebic liver abscess, which is caused by ant amoeba. So it's an ant amoeba which causes histolytica. Histolytica. The meaning of histolytica itself is that it is going to break the histocytes. So that is why it is going to cause amoebic liver abscess. I hope none of you will ever make the error. If asked, what is amoebic liver abscess? You're going to say histolytica. The name itself is telling you that it is going to cause lysis of the histocytes. Then amongst the cestodes, you have hydatid disease. Hydatid cyst disease. It is caused by the dog tapeworm. Okay. And then trematodes, you have the liver fluke. The name itself says liver fluke. And then the one topic which students dread the most because nobody teaches them well, it is the visceral larva migrans, which is a nematode. Actually, it is not supposed to cause disease in the liver. Nahi, chalana hai. Actually, it is not able to cause disease in the liver, supposed to cause disease in the liver, but it migrates there and ends up landing up in the liver. Okay, that is the problem. All right. Visceral larva migrants. Amoebic liver abscess. होता कैसे है? Feco-oral route. What is the mode of? चलाना है, ठंडा करना है. Amoebic liver abscess is caused by feco-oral transmission, है ना? Feco-oral transmission. क्या हिस्ट्री मिलेगी आपको? वाटर इंजेशन. ये क्या कर सकता है? बिकॉज ऑफ दिस impure water, it can lead to travelers diarrhea. It can lead to travelers diarrhea. So people who are travelers, they are drinking बिचारा non-boiled or non-mineral water, they usually get infected. क्या आएगा? What is the mode of infection? Feco-oral. What is the infective stage? It's the mature cyst. And a mature cyst always has 4 nuclei. 1, 2, 3, 4. 4 nuclei always. So what is the infective stage? It is always the mature quadrinucleate cyst. So you know that all protozoa, they either exist in the trophozoite stage or in the cyst stage. So all protozoa make trophozoite and cyst, and all helminths, they make adults, larvae and eggs. Okay. So over here, since it's a protozoan parasite, there will only be a trophozoite and a cyst. So cyst क्या करेगा? Mature quadrinucleate cyst आएगा. That is what is going to cause infection in us. Then the cyst is going to exist inside the stomach. Cyst खुलेगा, it's going to open up. The trophozoite is going to come out. Now this trophozoite can decide to cause disease in the intestine, causing amoebic dysentery. It can cause disease in the liver, causing amoebic liver abscess. It can also decide to go and cause abscess in the lungs or also in the brain. So this trophozoite is basically going to penetrate the intestinal wall. It is going to migrate with the portal circulation, and it can cause abscesses anywhere inside the body. Most commonly affected side is the liver, then the lungs and the brain can also get affected. Okay, who moves about? Thank you so much, Noor. Nice to know that you're liking it. Who is causing this? It is the trophozoite. So what is the infective stage? The infective stage is the mature quadrinucleate cyst. Either it can do non-invasive colonization, intestinal disease, or extra-intestinal disease, which can happen in the liver, which can happen in the lung, which can happen in the brain, like I said. Okay. And who is causing all of this? Who is responsible for all of this? The trophozoite. The trophozoite is the one which is its actively motile state. This is the one which is moving around in the body. This is the pathognomic stage. This is the one which is causing all of these pathogenesis, all of these diseases and problems. Okay, this is the one which is feeding. So this is the one which is going to feed on all your nutrition. This is the one which is going to create lysis of the intestinal wall. This is the one which is going to create these ulcers in the intestine and everywhere else. And this is the one which is the dividing state as well. So how is the parasite going to multiply? This trophozoite is going to do binary fission, divide from 1 into 2. So once you have ingested a mature cyst, it goes to your stomach, intestine, it exists, the trophozoite comes out. The trophozoite can then multiply and get excreted in the feces, or it can convert into a cyst stage which can get excreted into a feces. Whenever both of these get excreted into the feces, I will take the stool sample, put it on my slide, look under the microscope. So what are the diagnostic stages? Both cyst as well as trophozoite can be the diagnostic stage. If the trophozoite is coming out in the stool, it can be the diagnostic stage. If the cyst is coming out, it can be the diagnostic stage. The cyst, of course, is going to turn into first uninucleate, binucleate, then quadrinucleate. And only this quadrinucleate cyst or the mature cyst is what will come back and cause infection in the humans. Okay, only, always the mature, only. Okay, no other cyst stage can cause this. So you're specifically supposed to write about amoebic liver abscess. You're not supposed to write about intestinal amoebiasis. So what happened? You ingested the quadrinucleate cyst. It went to the intestine, cyst opened, existed, trophozoite came out. Trophozoite burrowed through your intestine, directly went to the portal circulation, and from there it reached the liver, settled in the liver and caused amoebic liver abscess. Okay, that is what is important. So amoebic liver abscess happens how? The infective stage of this is also the quadrinucleate or the mature cyst. You can easily draw the diagram of a cyst with the 4 nuclei, and the pathogenic or the diagnostic stage is the trophozoite of this. Why in amoebic liver abscess the diagnostic stage is not the cyst? Because cyst is only excreted in the feces. Okay, so actually the diagnostic stage will depend. The diagnostic stage will depend. So when I say diagnostic stage of entamoeba, diagnostic stage of entamoeba histolytica, what do I mean? I mean that if it is amoebic liver abscess, then the diagnostic stage is trophozoite only, because only these trophozoites will come out into the pus. If it is intestinal amoebiasis, which we will read in GI diseases, okay, which we will read in GIT. If it is intestinal amoebiasis, it can be trophozoite as well as cyst, both. All right, I hope you understand the differences. Now you will draw in the life cycle, there is a mature cyst which comes and a trophozoite which comes. Mature cyst is the infective stage, trophozoite is the pathogenic as well as the diagnostic stage. You ingest mature cyst through food and water. They exist in the small intestine, they enter the mesenteric veins, they go into the portal circulation, ultimately they land up in the liver, and in the liver they cause the amoebic liver abscess. What are the various pathognomic and basic important features of this? So who is the agent? Entamoeba histolytica. Okay, it is highly prevalent in the developing world. It's a poor country disease, and the male is to female ratio, nicely seen, is 9:1. So it has a lot more male predicament. The males are affected a lot more as compared to female. So you see that males are infected a lot more as compared to females. What is the main pathogenic factor? So when this trophozoite enters my liver, what are the main antigens which are causing the destruction? The gal and nag lectin. Please remember this. Gal nag lectin are essential for host cell binding and evading the complement mediated immunity. Okay. So what do the gal and nag lectin do? First, they evade my immune system and then they bind to the liver cells and invade these liver cells. Okay. What are amoeba pores? Amoeba pores are enzymes which form pores in the host cell membrane leading to cell lysis. What is cysteine proteases? They degrade the extracellular matrix, the IgA, which is coming to protect me, and they cause destruction. So, 3 important virulence factors are there for entamoeba histolytica. What are they? Gal-nag-lectin, amoeba pore, and cysteine proteases. So, gal-nag-lectin is the antigen which will help the amoeba bind to a cell. Then amoeba pore will create pores or holes inside the cell, and cysteine and proteases will break the extracellular matrix between the cells. And what will the proteases do? They will break the immunoglobulin, which is a protein. Yes, so protease will break immunoglobulins. So therefore the immunity can also not protect us. What are the features? If it is causing pain in the if it is causing abscess in the liver, where will the patient have the pain? Patient will have the pain in the right upper quadrant. So there is right upper quadrant pain. Okay? Scleral icterus. What is this telling me? This is of course telling me that there is jaundice. Whenever liver is involved, there is elevated liver enzymes, there is jaundice. So of course scleral icterus will be there. There will of course be hepatomegaly and hepatocellular damage. These are the clinical features, and one very important pathognomic feature is anchovy sauce pus or anchovy sauce pus. You have the characteristic chocolate brown or anchovy sauce brown pus which is seen. When you do a microscopy of this pus, you see that there are very, very necrotic hepatocytes, meaning destroyed and damaged hepatocytes, and less than 25% amoebic trophozoites are seen. Okay, so amoebic trophozoites are seen, but only less than 25% of the times. So what all will you write? You will write the infective dose, mature quadrinucleate cyst, the pathogenic stage, which is the trophozoite, then the lesions which are made the deep ulcers in the liver, leading to right upper quadrant plain, jaundice, hepatomegaly, and Ankervis pus. Right? What is the main virulence factor? Gall-Nag-lectin, amoeba pore, and cysteine and proteases. Okay, done and done. Then when you do the microscopy of this Ankervis pus, you will see that there is necrotic debris, hepatocytes, and plus and minus trophozoites, meaning less than 25% of the times you're going to see trophozoites, otherwise you're not going to see. So it's plus and minus. You can do the antigen or the antibody detection, of course, against whom? Of course, against the Gall-Nag-lectin, you're going to detect these. And of course, PCRs can be done, and ultrasound is the modality of choice to locate where the abscess is present. What is the summary? Infective stage is the mature quadrinucleate test. Pathogenic diagnostic stage is the trophozoite, Gall-Nag-lectin, amoeba pore, cysteine protease, Ankervis pus, and you can do microscopy, antigen, PCR, and ultrasound for this. Done and done. Right? Now you have the cestode. This is done. Now you have the cestode. Who is he? The cestode here is the dog tapeworm. You know that what are cestodes? Cestodes are tapeworms. So when I say fish tapeworm, pork tapeworm, beef tapeworm, dwarf tapeworm, dog tapeworm, all of it is cestodes, right? So here who am I talking about? I am talking about dog tapeworm who is giving the hydatid cyst disease. So a hydatid cyst disease can be of 4 types. One is the hydatosis or hydatid cyst disease, which we are going to read today, which is Echinococcus granulosus, which is called as the dog tapeworm because this guy right here is the definitive host. Actually, this disease is caused in dogs. Humans come in the picture by accident. So humans, they are a weird species. We enter where we are not needed. So the Echinococcus granulosus guy was happy causing diarrheas in dogs, happy causing intestinal tapeworm infections in dogs. We entered the picture for no absolute reason. What did we do? We came and we became an accidental host for them. Of course, there can be the polycystic disease, which is by Echinococcus vogeli, the unicystic disease by the oligarthus, and alveolar, which is the lung echinococcosis by the Echinococcus multilocularis. Okay, multilocularis. But who are we concerned with today? Only and only Echinococcus granulosus. So what is the mode of transmission? Mode of transmission is feco-oral by coming in close contact of dogs. Close contact of dogs because it's the dog tapeworm. Yes, what's the intermediate host? It's the human which was not needed. Who is the accidental host who has entered accidentally? It is the human. What is the infective stage of this? Infective stage is the embryonated eggs. What are we ingesting? The embryonated eggs. Like I said, all protozoa make cysts and all helminths, including cestode, trematode, nematode, they make eggs. Okay. Pathogenic stage. The pathogenic stage, classically, very, very characteristically for this is the hydatid cyst. Hydatid cyst. So almost always the students, they simply think hydatid cyst is the disease, and when you ask them the pathogenic stage, they are stumped because they are thinking of some trophozoite or some adult worm or some larva. But actually you have to say hydatid cyst. Hydatid cyst actually is nothing but kind of a larval stage of this. Okay. So the pathogenic stage and the disease name is both the same. Okay. It is hydatid cyst. All right. Let's look at it. So how is it going to come? This is a dog. Dog is the definitive host. This guy does not need humans. The parasite is going between dogs and some animals and it is happy. Who enters? Human enters by accident. So in human, the embryonated eggs, they get ingested by the human by accident. Then inside the human, it makes hydatid cyst in various organs. Now nobody is eating the flesh of humans. So humans are the accidental host as well as the dead end host of this disease, right? They are also the dead end host. So they are the intermediate host, they are the accidental host, they are the dead end host. Who? humans, okay, because it was simply supposed to move between animals and dogs. So from the dog it will go to a sheep. In the sheep it will create hydrated cyst, then it will come back to the dog because dog will eat the meat of the sheep. But instead of the sheep, if human comes in the picture, then it gets formed in the human body, and nobody eats the meat of humans, therefore humans are the dead end host. ठीक है, humans are the dead end host. Done and done. So helminthic infections, what was I saying? Cestodes, hydrated cyst disease caused by Echinococcus granulosus. It's D for dog, D for definitive host. Accidental, intermediate and dead end host is whom? It's the human. What does a hydrated cyst look like? Please draw the diagram of a hydrated cyst. Okay, so what happens in a hydrated cyst? You have the parasite, okay. Parasite is going to produce the inner layer. Inner layer is also the germinal layer. This is from where the babies are going to come out. On top of this germinal layer, the parasite itself will deposit another layer on the outside. Okay, what is this layer now? This is the ectocyst. So on the inside you have the endocyst, on the outside you have the ectocyst. Okay, so what are these? These are ectocyst and endocyst. Even outside this, there is a fibrous reaction of the body. What is that? Pericyst, something which is formed around the hydrated cyst. Okay, so up till this green thing is the hydrated cyst itself. A layer which has been created by my body to cover the hydrated cyst is something which is outside the hydrated cyst. That is why this is labeled as pericyst. Pericyst. Who is making the pericyst? It is the host which is making the pericyst. What is this? It is ectocyst. Ectocyst. And what is this? This is the endocyst. Endocyst. Who is making ectocyst and endocyst? It is the parasite which is making the ectocyst and endocyst. Okay? Then what is endocyst? It is also called as the germinal layer or germinal layer. This is the one which is going to give rise to babies. How do the babies get produced? There is a stalk which comes out. Then there is a capsule which forms. Inside this capsule, there is the heads of these small little babies. What are the heads of this parasite called as? Scolex. Multiple is scoleces. So this is a capsule which is a breeding ground for these scoleces. So what is this? This is a brood capsule. Brood capsule. And what does the brood capsule have? It contains the protoscolex. Protoscolex means primitive scolex, something which is going to become the adult head tomorrow. Today it is primitive. So it is protoscolex. Now, some of these brood capsules will detach from the germinal layer and they will become separate. So of course there is the protoscoleces on the inside of this capsule. Now this one will start behaving like a hydrated self in itself. So it will start depositing this ectocyst layer also on itself. So isn't this like a daughter who's trying to imitate the mother? Isn't this like a pregnant belly which has its full born baby, fully made baby? So this whole thing with the ectocyst is called as the daughter cyst. So it's a full hydrated cyst inside a adult hydrated cyst. This is a daughter cyst. Sometimes these brood capsules, they burst, and when they burst, all of these protoscoleces, they come and they settle at the bottom. Okay, this is called as hydrated sand. What is this? This is hydrated sand. This hydrated sand, along with the hydrated fluid inside this structure, is highly anaphylactic. That is the biggest problem with the hydrated cyst disease, that it is anaphylactic. Thank you so much. Happy Guru Purnima, guys. Thank you so much. This is anaphylactic. This is going to cause anaphylaxis reactions inside the patient. This is the problem. Not difficult at all. Not difficult at all. Please draw the hydrated cyst in your exams. This is not difficult at all, guys. All right. Done. So we were just seeing the hydrated cyst. There is a pericyst which is host derived fibrous tissue. Inside is the ectocyst which is hyaline. Endocyst which is the germinal layer. It produces the daughter cyst and the hydrated sand. All right. And we will draw that too. What are the complications? Pressure effect, right? If it is forming in the liver, it is going to cause pressure effects in the liver, leading to enlargement, hepatomegaly. If it is present near the bile duct, it is going to obstruct the bile duct, leading to cholangitis. Spontaneous rupture can happen, and if this thing happens, it is a big problem. If this ruptures spontaneously, then all of this hydrated sand is going to come outside, and it was anaphylactic, so the patient will land in anaphylaxis, and it can be very, very life threatening. So a hydrated cyst should never burst. A hydrated cyst should never be made to undergo FNAC or biopsy of any kind, because you cannot afford to burst a hydrated cyst. Diagnosis is radiology. On USG, you see the water lily sign. And then what is the treatment of choice then? The treatment of choice is the pair procedure. You cannot do FNAC. You cannot do biopsy. You do an ultrasound, you see a water lily sign. Next thing you do is pair. Pair stands for puncture, aspiration, injection, and reaspiration. So you simply go subcutaneously, intradermally, percutaneously, and you just puncture the cyst a little bit. Then you aspirate out around 10 to 15 ml of hydrated fluid. Then you inject back inside normal saline, because normal saline is colicidal. So all of this hydrated sand is going to die because of normal saline. It is going to kill these protoscolex or these scolices inside, right? So it is scolicidal. And now when all the anaphylactic things are dead, now you aspirate it nicely. You now totally re-aspirate it outside. So first you puncture, then you aspirate, then you inject the poison, and then you re-aspirate everything outside. It is contraindicated in extrahepatic and communicating cysts. Okay. So if it is a cyst which is communicating with other organs, then it's a pair repair is not indicated. All right, done and done. Then we have the trematodes, which are the liver flukes. Very, very easy, very, very simple. All trematodes have one common rule. All trematodes are going to have operculated eggs. What are operculated eggs? Eggs with a lid, either with a lid on top. So you can see that this is an egg, and on the egg over here there is a lid. So what is this? Egg with a lid. They are called as operculated egg. What is the adult worm going to look like? This is the adult worm. It is leaf shaped. It is leaf-like. That is why it is given the name fluke. If this fluke goes and affects my liver, I call it as the liver fluke. Goes and affects my lung fluke, intestinal fluke, blood fluke. Okay. So trematodes are very, very simple. All of them have these operculated eggs. All of them have these leaf-shaped bodies. The only exception to this is the schistosomes, which we are going to read in the urinary bladder diseases. Okay, not a problem. So, of course, liver fluke is going to have operculated eggs, and liver fluke is going to show me the leaf-like body. What are the important liver flukes? Fasciola hepatica or fasciola gigantica, which will cause infection of the liver as well as the bile duct. Then you have the clonorchis and the opisthorchis, which is only going to infect the bile duct. Who's the intermediate host? They have two intermediate hosts. All trematodes have two intermediate hosts. The first host is always the snail. So the definitive host is always the human. Then there are two intermediate hosts for all trematodes, for all flukes, liver, lung, anything, all flukes, okay. And the first one is always and always a snail. Then the second one is an aquatic plant. So whenever it is anything with the letter F, so it could be Fasciola hepatica, it could be Fasciola gigantica, it could be Fasciolopsis busci, whichever trematode, if it starts with F, it is caused by a fresh aquatic plant. Caused by a fresh aquatic plant. Example, water chestnut. Water chestnut. Right? If it has the sound of kiss, kiss, it is going to be caused by fish. Fish or fish. Okay? So, clonorchis, opisthorchis, second intermediate host is fish. So, Fasciola hepatica, Definitive host human, first intermediate host snail, second intermediate host fresh aquatic plant. Clonorchis opisthochis, definitive host human, first intermediate host snail, and second intermediate host is the fish. All right, this is the rule, general rule. And fasciola hepatica is the only one which is going to affect the liver. The other two are only going to affect the bile duct. Bile duct. So how will you draw? You will say that classification of liver flukes could be that they could be fasciola hepatica or they could be clonorchis sciences and opisthochis. Okay. The fasciola hepatica infects liver as well as bile duct. It is also leaf shaped. This one affects the bile duct only. This is also leaf shaped. Now, clonorchis and opisthochis is strongly associated with cholangiocarcinoma. So, what are they going to cause? They are going to cause bile duct cancers. Bile duct cancers or cholangiocarcinoma. Whereas this guy is not going to cause any kind of cancer. Okay. So, hepatica is strictly no malignancy rule. Okay, no malignancy policy. What is this? Life cycle. See, whenever you get a question on any flukes, feel very happy and very lucky. Because while most students are scared of the life cycle of flukes because of the so many larval stages, it is actually the easiest thing to draw in exam. So whenever you get a question on any fluke, please draw this life cycle. There are 5 larval stages to any fluke's life. Okay, you have excreted. So what will happen? As a human, you will excrete these operculated eggs in your feces. These eggs will go into the water body. Over there, these eggs will hatch. From the eggs, a larva will come out. Then that larva will change into 5 larval forms until it becomes the infective stage, which is the metacercaria. Where will this infective stage go? This infective stage will go onto these guys, onto the snail and the aquatic plant. Okay. So, you as a human, you have excreted the eggs. Eggs have gone into the water. They have hatched. The first few larval stages, they come out into the water. Then they go into the snail. Then the last stage, it comes out of the snail, goes into either the fresh aquatic plant or the fish, and then you ingest that aquatic plant and the fish, along with you ingest the last larva. Okay, and that is how you get the infection. So what are the larval stages? Miracidium, sporocyst, rhedia, cercaria and metacercaria larva. How to remember? So all of these stages are in the snail, which is the first intermediate host, and this last stage is there on the aquatic plants, on the fish. That is why this becomes the infective stage. So what is the infective stage of liver fluke? It is metacercaria larva. Okay, then how to remember this? You have a beautiful mnemonic. Mnemonic is my silly red cat. My silly red cat meows. Okay. My silly red cat meows. So, Miracidium, sporocyst, rhedia, cercaria, metacercaria larva. So, be happy if you get a trematode, because that is one guy where you can draw this life cycle. Okay. What is the life cycle? Egg hatches in the water, Miracidium comes out, then sporocyst and rhedia. All of these are present in the first intermediate host, which is snail. Then the cat cercaria larva comes out, converts into metacercaria. This metacercaria goes to the fish or the aquatic plant, which we ingest, and this metacercaria becomes the infective stage to humans. Done and done. Done and done. And the clonorchis and opisthochis are going to cause cholangiocarcinoma, the cancer of the bile ducts. So when you compare and contrast the cestode and a fluke, so the hydrated cyst caused by Echinococcus granulosus, definitive host is a dog. The human is an accidental host, intermediate host or a dead end host. The complications are hepatomegaly, cholangitis, and anaphylaxis on rupture. On ultrasound, we see the water lily sign. We do the pair procedure if it is suitable. However, pair is contraindicated if it is an extrahepatic or communicating cyst. Whereas for liver fluke, you have fasciola hepatica or clonorchis and opisthoarchis. Fasciola hepatica causes liver and bile duct involvement. Clonorchis opisthoarchis only involve the bile duct. My silly red cat mews is the life cycle. Ultimately, metacercaria is what becomes the infective stage. Good evening, Saurav. Good evening. Okay. Then clonorchis opisthoarchis, they cause cholangiocarcinoma, whereas fasciola is not associated with malignancy. Everything revised, done and dusted. The last guy is the nematode. It is visceral larva migrans. Everybody is always so confused about visceral larva migrans. What happens? What is the meaning of larva migrans? It means wandering parasite. Okay, what does it mean? It means wandering parasite. Aberrant or wandering parasite. So this parasite has come where it does not belong. Okay, it has entered a host where it did not belong. Now it does not know where to go. So it's just randomly migrating in all of the body. So when I say larva migrants, I mean aberrant parasite, but I can mean cutaneous larva migrants, where it is literally running about under our skin. Yes, Nishkesh, you can. Or it can, but you have to be really devoted to it, okay? And it can be visceral larva migrants, wherein it is just running about inside my organs. If it is cutaneous larva migrants, it can be because of two guys. One is the hookworm, especially Ankylostoma brasiliensis. So just remember that you migrated to Brazil. What did you do? You migrated to Brazil. So it is Ankylostoma brasiliensis. Then another important guy is strongyloids, which causes larva currents. Why currents? Because it spreads like a current very fast under the skin. Okay, larva currents. See, I have written currents only. currents. It moves like a current, but it is called currents. Then you have the visceral larva migrants. What is visceral larva migrants? It is now roaming about in my organs. It can go to the liver, it can go to the eyes, it can go anywhere in the organs, right? Example, one is of course this strongyloids guy only. One is of course strongyloids. But another one is Toxocara canis. Toxocara canis. Now, canis is who? Canis is dog. So, this guy is actually supposed to cause infection in dogs, not in humans. So, please remember, dog tapeworm is hydatid cyst. Toxocara canis is larva migrants. Now, this is a aberrant parasite or wandering parasite. It has entered an accidental host or a paratenic host. What is a paratenic host? A paratenic host is somebody who's not needed in the life cycle, and in this guy, the life cycle gets arrested. Okay, in this guy, the life cycle gets arrested. What is the meaning of this? I will just tell you. What happens here? Life cycle of parasite gets arrested in this host. What is the meaning of that? For that, you have to look at the life cycle. Don't be scared of the life cycle. See, this is the dog. The dog has eaten a small little animal. The dog has gotten the Toxocara canis. Now, in the feces of the dog, The unembryonated egg is coming out. Egg is embryonating. Embryonated egg means egg which has the larva inside. Okay. These embryonated eggs are lying around in the soil. From that soil, these small little animals, they eat the egg. Inside their body, this larva comes out. Now this larva is arrested in their body. The larva cannot develop into an adult and keep laying eggs. Now this larva is arrested. This larva does not know what to do. So larva is just roaming about. It is just wandering. Okay. Similarly, this paratenic host, instead of being these small animals, can be this big animal here, which is the human. Now, normally in the environment, dog excretes the egg. Egg is eaten by small animals. Small animals are again eaten by dog, and the cycle continues. The problem comes when this egg is ingested because of soil contamination by the human. Human ingests the egg. The larva comes out in the human's body and it does not know what to do. So larva is just migrating and nobody eats human flesh. So it gets arrested there. It is the dead end of that parasite. So it is just migrating in the visceral organs. So what you will draw this life cycle, you will write ingestion of embryonated eggs containing the L3 larva from contaminated soil and environment. The eggs, they hatch in your small intestine, they release the larva. The larva penetrates the intestinal wall, enters your blood. Now the larva is in circulation. Now it will migrate as larva migrants through the various organs, to the liver, to the lungs, to the eyes, to the other tissues. It accumulates in these organs, causes tissue injury and inflammation, therefore leading to larva migrants. So what's the causative agent? Toxocara species. What is the mode of infection? Ingestion of embryonated eggs containing L3 larva from the environment such as the soil. The definitive host is dogs and cats, and in them, the adult of the parasite lives in the intestine of dogs and cats. A paratenic host or an accidental host in this case is the human, and human is also the dead end host here. Human is also the dead end host in this case. Pathogenesis, you have just seen the above diagram. Main organs are the liver, lungs. Most commonly, it can also be present in other tissues. What is high yield? Human infection is accidental. Larvae do not mature in humans. They cause tissue damage. So what is the human in this case? The human in this case is a dead end host, is a accidental host, is also a paratenic host. Is also a paratenic host. That is what a human is in larva migrans. Done and done, guys, right? So thank you so much for attending. Like I had said, hepatobiliary system, maximum scoring, smallest, beautiful unit. Most students are scared of it. I hope you won't be scared of it anymore, right? You can, of course, access the lectures. You will be given the PDF. You can access them on the app as well. And very soon, I'm going to see you tomorrow itself on another lecture where we cover another important unit. Till then, thank you so much. Good night. Bye-bye. Please connect on my social media if you have any doubts. Thank you, guys.